Hello everyone, this is Dr. Vishal Gyawali from Queen's University, Kingston, Canada, and today it's my big pleasure to be speaking with you about surrogate endpoints in cancer drug trials and their validity as a part of the course for Masterclass in Critical Appraisal created by the Queen's University Global Oncology Program. So in my talk today, first I'll be talking about what a surrogate endpoint means and what are some commonly used surrogate endpoints in cancer drug trials, and what constitutes a valid surrogate endpoint, and some differences between predictive and prognostic biomarkers, and some examples of pitfalls of relying on surrogate endpoint, and a couple of slides on what informative censoring means and why we should care about it. This lecture will not be an exhaustive lecture on everything related to surrogate endpoints, but just a primer on key topics that you need to know while reading about surrogate endpoints or reading cancer drug trials that have used surrogate endpoints. So first, let's talk about why a patient with cancer takes cancer drugs. Because we know that cancer drugs have many side effects, some of which can be serious or even fatal, and they are also quite expensive. So despite these caveats, why do we prescribe cancer drugs and why do patients take cancer drugs? There are only two reasons: because they expect that taking cancer drugs will help them live a longer and a better life. Ideally both, but at least one of them, a longer life or a better life. But if we look at many cancer drug trials, we find that the trials are not necessarily measuring those outcomes. They are measuring something else. Measuring longer life is measuring overall survival, and measuring quality of life is measuring quality of life in terms of trial endpoints. But we see that many drug trials actually use a different endpoint, and that is called surrogate endpoints. These surrogate endpoints are not direct measures of clinical benefit. So some of the commonly used endpoints in oncology trials are response rate, which is defined as the percentage of the patients that achieve a response. And response in turn is defined as a shrinkage in tumor size by at least 30% or more. I think you will have another lecture on how to define response in progression in stable disease based on the RECIST criteria. Similarly, there is something called progression-free survival, which is commonly used in oncology trials. This is the time after the start of treatment until disease progression or death. And then there is time to tumor progression, which is basically like PFS but does not include death. And there is disease-free survival, which is also like PFS but in the adjuvant setting. And there is pathological complete response rate, which is the percentage of the patients who achieve pathological complete response after neoadjuvant chemotherapy and surgery. And then there are some other unique endpoints used in a specific setting, like metastasis-free survival in prostate cancer, event-free survival in breast cancer, and so on. So we discussed that we use cancer drugs to improve survival or quality of life, ideally both. So the question is, why do we use surrogate endpoints in trials then? Because using surrogate endpoints like responses or progression-free survival saves time. It takes longer to measure overall survival. And thus we are saving time. That means we are completing the trials early, we are publishing it early, and the drug is getting approved early, and patients are having access to the drugs early. That's the reason why we are using surrogates. But an important question is, how much exactly are we saving in terms of time by using surrogate endpoints in place of overall survival? And this question was somewhat answered in 2019 in this JAMA Internal Medicine paper, in which they showed that using response rate instead of overall survival would shorten the study duration by a mean of 19 months. And using PFS instead of OS reduce the trial duration by an average of 11 months. So there is some time saving. If you are using PFS instead of OS, there is time saving in like a year. And if we are using response instead of OS, we are saving time by nearly 1.5 years. But it's not that big of a difference. Sometimes people think that we are saving 5 years, 6 years by using surrogate endpoints instead of overall survival. No, that's not the case. There is some time saving, which is there, of course, a year and a half, but it's not like 5 years or 6 years. And why is this important? This is important, to think about the trade-offs. Okay, yes, there is time saving of 1 year, 1.5 years, but what is the drawback? The drawback is we could be misled. The drug may not improve survival. For example, the Bolero trial of everolimus plus exemestane in breast cancer. The first publication was in 2012 in New England Journal of Medicine, which showed a good difference in progression-free survival, but the overall survival results were published just in 2014. After just a couple of years, we had overall survival results, and the overall survival showed that actually there was no difference in terms of overall survival. So the one might ask, is using surrogate endpoints always a bad idea? The answer is no. There are differences between good surrogate endpoints and bad surrogate endpoints. Or technically speaking, valid surrogate endpoints and invalid surrogate endpoints are not yet validated surrogate endpoints. So for an endpoint to be used as a good surrogate, as a valid surrogate endpoint, what we need to show is that that surrogate endpoint correlates strongly with the clinical benefit, such as improving OS and improving quality of life. So there should be a good correlation between improving the surrogate endpoint and improving the clinical outcomes. And according to the FDA says that the clinical trials are needed to show that the surrogate endpoints can be relied upon to predict or correlate with clinical benefit. And those endpoints that have undergone this sort of testing, correlation testing, are called validated surrogate endpoints, and this can be used as an evidence of clinical benefit. But if the surrogate endpoints have not undergone this testing, then they are not yet validated, or they have undergone this testing and have shown that there is poor correlation, then those are invalid surrogate endpoints. So whenever we see a surrogate endpoint as a primary endpoint in a clinical trial, we should first check whether it's a valid surrogate endpoint or not a valid surrogate endpoint. In 2018, this paper was published that looked at the strength of validation of surrogate endpoints across different tumor types and across different settings, neoadjuvant, adjuvant, metastatic settings. And they found that in majority of the cases, the correlation between surrogate endpoint and overall survival was low. There were only a few cases where the correlation was high. And sometimes people think that, okay, maybe the correlation with overall survival is not great, but if we are delaying progression or creating a response, probably it correlates with better quality of life. And quality of life is also a clinical endpoint. So what about it? That's an excellent question that has not been properly studied for a number of endpoints. For progression-free survival, we studied that question in 2018. We published this paper in International Journal of Cancer. We looked at whether improving PFS correlated with improving quality of life. And with PFS, this question comes a lot because there is a belief that delaying progression automatically translates into improving quality of life. That is partially true, but quality of life is affected not only by disease progression, it is also affected by toxicities of the drug. And when we're talking about disease progression, we're talking about increase in tumor size by more than 20%. So that particular 20% benchmark is not necessarily a magic benchmark that anything beyond that will create impairment in quality of life. So in this paper, we looked at 352 phase 3 randomized trials in oncology, and we found that the first problem was that half of them, they did not even include quality of life as an endpoint. So many trials do not even measure quality of life as an endpoint. And of those that did, a quarter did not report on pre-specified quality of life endpoints. So there is this issue of publication bias with quality of life data. But with whatever data we had, when we analyzed, we found that the association between improving PFS and improving quality of life was very weak. So PFS is not a good surrogate for quality of life. If you want to prove that the quality of life has improved, you have to measure quality of life and you have to show it. You cannot guess it based on improvement in PFS. So we talked about valid surrogate endpoints and non-validated surrogate measures. Let's talk a little more about how do we actually validate the surrogate endpoints. What's the process? So this is how we validate a surrogate endpoint. We we plot graph between the clinical endpoint and the surrogate measure, and we see whether there is a strong correlation between the clinical endpoint and the potential surrogate endpoint. You may have seen many such analyses in the literature, but we need to be careful what these analyses are really testing. For example, this first graph is median OS versus median PFS. This is testing patient level surrogacy. What we need is trial level surrogacy. Can this surrogate endpoint be used in clinical trials to predict clinical benefit? So that is trial level surrogacy testing, and for that we should measure the treatment effects in OS correlation with treatment effects in the surrogate endpoint. So if we are measuring median OS versus median PFS for the drug, that is patient level surrogacy. But for trial level surrogacy, we should measure median OS in the experimental arm minus median OS in the control arm versus median PFS in the experimental arm minus median PFS in the control arm. Or we can also measure treatment effects in terms of hazard ratios. So as shown in this graph, log of hazard ratio for OS versus log of hazard ratio for PFS. So the key point is treatment effects must be measured to prove trial level surrogacy. Simply median OS versus median PFS does not prove trial level surrogacy. And the other question is, what level of correlation is sufficient to say that, okay, this is a good surrogate endpoint? And there is, I guess, no uniform consensus on this, but the commonly used criteria is from the German group, and that says that the correlation coefficient of more than 0.85 or the coefficient of determination R square of more than 0.7, which is basically the same thing, provides a proof of a strong correlation between the surrogate endpoint and the clinical benefit. So just to recapitulate, a good patient level surrogate and a good trial level surrogate are different things. A good patient level surrogate can be used as a good prognostic marker. For example, pathological complete response in breast cancer. Patients who achieve pathological complete response will have longer OS. That's true. But a drug that improves pathological complete response may not improve overall survival because it's a poor trial level surrogate, despite being a good patient level surrogate. A good trial level surrogate predicts treatment benefit in trials and can be used as a surrogate endpoint. And one good example is disease-free survival in colorectal cancer. For breast cancer, just to give an example of different surrogacies, pathological complete response does not correlate well with OS. Disease-free survival does not correlate with OS overall, but only in HER2 positive subgroup there seems to be a strong correlation. Response rate does not correlate well with OS. PFS, there is mild to moderate correlation only. It's not sufficient to be used as a surrogate for overall survival. And in case of event-free survival, there is a moderate correlation. So this question about whether a surrogate endpoint is valid is important to predict the treatment effects on overall survival. But many times I see that people are debating about validity of a surrogate endpoint when overall survival results are already available. When OS results are already available, you no longer need to predict them. So whether a surrogate endpoint is valid or not is a moot point when OS results are already there. For example, this is a recently published trial, NALA trial in breast cancer, and it shows that the median PFS improved by 0.1 month, 5.6 versus 5.5 months. Although this is such a small marginal difference, the p-value was significant. And when people were talking about this trial, people were talking, oh, is PFS a valid surrogate in this case for OS? But the fact is that the OS results were already available. The OS results was already published, and it did show that the OS was not significant. So in this case, whether or not PFS is a valid surrogate for OS is a moot point because we already know that the OS was not improved. We discussed earlier that using surrogate endpoints will save some time compared to using overall survival. However, we should also keep in mind that sometimes even after multiple trials, the surrogacy may not be fully established. We studied that for bevacizumab trials in breast cancer, and we found that there were 7 clinical trials, and even at the end of 7 clinical trials, we could not conclude whether PFS was a good surrogate for OS or not. So even after multiple clinical trials, the question to is PFS a valid surrogate for OS for bevacizumab trials in breast cancer was not answered. The answer was maybe, could be, we do not know. So in the long run, I think that it is far more efficient to conduct a proper clinical trial with OS as the primary endpoint than to run a number of trials with surrogate endpoints and not know whether that translates to OS or not. Now, we have seen that in the recent past, the FDA has withdrawn approval of 4 drug indications because they failed to improve survival, although they had previously improved a surrogate endpoint. And there are 6 other indications currently under review for the same reason. For all of these cases, these drugs were approved on the basis of response rate, which is a very poor surrogate, and they failed to improve overall survival in the confirmatory trial. So this shows that relying on surrogate endpoints can sometimes mislead us, and that drug will end up not improving any outcome or sometimes even harming patients. It is also important to understand the concept of censoring to further understand the pitfalls of using surrogate endpoints. Censoring refers to patients who do not complete the clinical trial in full and they drop out in the middle. And usually when patients drop out, there is equal number of or balanced number of patients in the both arms who drop out from the trial, and we believe that that does not impact the results, so we call it uninformative censoring. But sometimes the drug might be having lots of side effects, it could be less efficacious, so the patients might be dropping out more in one arm than the other, and in that case that will affect the results, and we call it informative censoring. Here I have provided some references if you want to study about censoring in detail, but in summary, because of this unbalanced dropout between the arms, especially of patients who are having side effects or who are performing poorly, the drug might look to be better than it actually is in terms of progression-free survival. So there are some ways that have been suggested to address this. And one is to use overall survival rather than the PFS as the primary endpoint. That will take care of this issue of informative censoring. And the other is to also look at time to treatment failure in addition to progression-free survival, because time to treatment, in case of time to treatment failure, that will have been accounted for. So the difference in time to treatment failure will not look as impressive as the difference in PFS. And the other is to just list the regions for censoring so that we know whether that censoring is whether the censoring is happening due to side effects, due to lack of efficacy, or due to some other reasons, and to perform a sensitivity analysis using the best case scenario, assuming all censored patients do not have disease progression, and the worst case scenario, assuming all censored patients have disease progression. Thank you very much. I'm happy to take any questions. If you have, please feel free to email me or tweet at me. Thank you.